Good morning.
Good morning. We can hear you. Yes, we can hear you and see you.
So, this is a case of duodenal neuroendocrine tumor. Do we have a history slide? Okay, so this is a case of duodenal neuroendocrine tumor, which is located on the posterior wall. You can see here, I'm going with a cat, and I have with me Tom from Muscat. And you can see here, he will guide me. What do you think about this lesion? Yeah. Okay, so we have many options available to treat neuroendocrine tumor. One is binding EMR, which is the most easy one, but it is for only submucosal lesion. But those who are affecting the muscle, we need a full thickness resection. And duodenal wall is very thin, and doing ESG in duodenum is quite challenging because you may perforate. So other options are to do freehand EFTR, that is full thickness resection, but we have to be ready with the closer devices. So here we have a device which is over the scope device, and this is known as OTSD FTRD device. So I have mounted a cap and I have gone to the duodenum and I am inserting the tumor there, and I will just try to do, and I mark that area all around. You can see that the markings are there. The markings were done by post coagulation, and then I am trying to do a grasper. I use the grasper with this to bring it into the cap. So I must go inside the duodenal barrier, and then encase it and do gentle suction so that I can see the mark. You see that the mark, you can see the mark. Yeah. Yeah. So that's the mark. So I have two kinds of mark. One is the last on the distal anal side, and one is on the this side, oral side. So I do gentle suction to bring this inside here, and then I use this grasper to bring it open, please. Close. So I'm just bringing that inside, you see, with the suction, gentle suction, and so once it is quite, so I'm just doing a gentle grasper.
So,
I use a sequence of events that is known as to apply the clip, and as soon as I apply the clip, I see the blue marker there. Okay, so you can see according to the guideline, and the options available to us are either to do a full thickness resection or to do so that's the problem with the grasper here. It brings a lot of bleeding.
Can I ask a question to the panel, or we ask directly?
What's
Feel
the
free to ask
maximum
whatever question you
size?
want, either to us or the.
I don't want to disturb him because he needs to focus on the procedure. But in this situation, I would not use a grasper because grasper is going to compromise. So he should gently suck that in and deploy. This is what happens with grasper is it traumatizes the tissue. You get blood, you lose your visibility.
So I think the comment is, there's a fine line between grasping because you can, traumatize the area a bit and make it harder to see. My understanding is usually when we use these FTRD devices, it's not purely just suction, but it needs to be, a component of grasping, because there's some concern that if you just suction, you may get sort of what's outside on the other side. And there's been documented cases of, colonic and even sigmoid FTRDs where the ureters have been actually caught in these lesions, and patients came in with obstructive uropathy. So, the way I was taught, and at least from the manufacturers, is it's really a combination of grasping and a bit of suction, and not just one or the other.
Can you hear me? Hello? Nothing.
Sometimes what happens is when you grasp the femur with the grasper, it causes mucosal ulceration or erosion and it bleeds. So what I do is I wait for 2 minutes for the bleed to stop and do proper suction. It's better to do suction and then wash this area like this, just to be sure where we are. The position is slightly difficult for me. Okay, so what I'm doing is I'm repositioning.
Mohan, it's Pradeep here. Can you hear me?
Yes, yes,
I just wonder whether you take your grasping forceps out, put some infacol down, because there's so much bubble, the visibility is compromised here.
unfortunately that is not available.
Oh, so sorry. I could have brought with me from England if I'd known. Because I think visibility is key here. And
So
you,
I'm seeing the femur is now in.
the, the duodenal nets in the cap are very, very tricky because your position is unstable.
So I'm trying to grab this close and then bring. It's quite hard femur there, so I have to use some suction.
So if it is hard, that means it is type 3?
Yeah, you can change and then see. So what I do is sometimes use this band ligation device to completely obliterate the base like this. You can see just to cut off the blood supply. Now, advantage is that this is quite a safe procedure and the graft size is slightly bigger and suction is allowed to do in band EMR because if you do suction, you will not cut off the muscle mostly,
So, Dr. Mohan, you will snare it after the banding, or? So will you snare it off now that you banded?
So Dr. Sarah is asking, are you planning to snare it after?
So bands usually fall down in varices, but what about this one? Does it fall down or it is? After how many days?
And then so you mentioned you would repeat the EGD in 2 months. Would you biopsy routinely, or how do you ensure the margins were negative and there's no recurrence? You mentioned you would do a repeat EGD at 2 months for surveillance. Would you biopsy to make sure the margins were negative, there's no recurrence? So is there any other follow-up you would do, Dr. Mahan? Like, for example, chromogranin A, if you have a baseline, do you repeat it after resection or? There's one question. Was,
So if you have one lesion, you need to do pan endoscopy to look for others.